Welcome to the Real GI Doc Show. I'm your host, Dr. Fred Gandolfo, and I'm a board-certified gastroenterologist with a medical practice in New York. Today's episode will be relatively quick and straightforward. It's a little more Q&A, and I had a recent question from a listener that I thought was interesting, and I wanted to get it done. And I also have a pretty long email that I was written about colonoscopy that basically summarizes the questions that lots of patients ask. So I figured it would be a good email to read out and answer kind of off the cuff. I didn't really prepare much for this. This is like within the wheelhouse of just general chit chat that happens in the office. So I figured if one person needed to know this, had the answer to this question, then there'd be many other people who could benefit. So first, I'd like to just get to the question that was submitted. And this is from a listener named Gail. And I would also like to invite you to send some questions over. You can use the link that's in the show notes. It's a link that goes to a site called SpeakPipe. And on SpeakPipe, you can leave a 90-second or less question for me. So a minute or two, actually a minute and a half or so is the limit. But that's pretty much all you need to leave a somewhat concise question to me, and I can answer it on an upcoming show. All right, here is Gail's question.
Hello, my name is Gail, and I had some genetic testing done, and they told me that I had the MUTYH. Is it pronounced muse? I'm not pronouncing it correctly, I know. They said that I had that gene and that the risk of colon cancer was greater as a result of that. So I'm wondering if you can tell me what that gene really means and what it might do and what I can do to make sure that I don't get cancer. So I would appreciate knowing more about that. Thank you.
All right, so that was a question about a condition called MUTYH, or she had different ways to pronounce it, and I don't truthfully even know the right way to pronounce it. I think it's just whatever people say at conferences and things, but I've heard MUTYH, M-U-T-Y-H, and it's basically a genetic mutation that is recessive, meaning both of your parents have to carry a copy of the abnormal gene, and then you get that abnormal. If you get that combo from your parents, you get one gene from each parent that's abnormal, then you develop this syndrome called MUTYH polyposis syndrome. And it's relatively uncommon, although you do see it occasionally. And we kind of treat it like other polyposis syndromes, meaning it's a syndrome that causes you to form lots of colon polyps and often colon cancer, because polyps turn into cancer, and people who form lots of polyps get cancer at a higher rate. So if you have MUTYH, if you have both genetic mutations, so meaning like you carry both copies, then you have the true syndrome. And really, you're supposed to be screened very closely for colorectal cancer with a colonoscopy every year or two, starting around the age of 25 or 30. And sometimes you have to take into account the rest of the family history there too. But for the average person, you basically should get lots of colonoscopies every year or two, and you'll find polyps, and the doctor takes them out, and eventually it just has to stay on top of it and just do frequent screening or surveillance colonoscopy, you'd call it. So lots of colonoscopies, and also you're at risk of having polyps in the stomach or the small intestine. So you do endoscopy every once in a while as well. You don't have to do it as frequently, really, as the colonoscopy, but typically you would do endoscopies with the colonoscopies, or you do them a little less frequently, every 3 years or 5 years. And depending on what you have, really, on the endoscopy is how you go from in that department. So if you have lots of polyps in the small bowel or in the stomach, then you do more frequent upper endoscopies. But a lot of people have nothing in the stomach or the small bowel, so you can stretch those out a little bit longer if you'd like to. And there's other cancers that you're at higher risk for if you have both copies of the mutated MUTYH gene. And basically, this includes thyroid cancer and bladder cancer, ovarian cancer, skin cancers, and a couple of other rare cancers. So you really should see you should get guidance from your local doctor, of course, as to what other screenings to do. You can consider genetic counseling to see the deal with the family members, and if they should get screened too, which they should. Really, any children should get screened, siblings should get screened. And really, that's the story. So lots of colonoscopies if you have this particular condition. And how would you know if you had it? Well, you have to send it, your doctor would have to send a genetic test for it. It's picked up on a blood test, and we do these blood tests in the office. They're very easy. They take 10 to 14 days to get the results from. And if you have a family history that supports that you might have a problem like this, or if you have multiple colon polyps, like if you have your first colonoscopy at 50-something and you have more than 10 polyps, that's someone that you would think to test for. It's not mandatory, but it's one of those things that you think about, especially if there's a family history of some of these other cancers. And once you have the diagnosis, you just follow up very closely. It's similar to the way we follow up other patients with other genetic cancer syndromes. And I covered some of this stuff on that previous episode where I was the guest appearance with a Lynch syndrome patient / advocate. And I can link that below as well for more information about how to prevent colon cancer in general, especially if you're high risk. But it does come down to healthy living, healthy lifestyle, whole foods, lots of plants, a little less meat than the average person, and watching out in terms of the body weight, not smoking, not drinking alcohol. We're limiting all those things as much as possible, and getting some exercise. And that's really what you do to prevent colon cancer. So you do all those things, the healthy living stuff, and you get your screenings and surveillance exams much more frequently than the average person. If you don't already have a gastroenterologist, of course, you should have one locally to you who can do all these tests. So obviously you have to get your GI doctor up to date with the genetic screening and follow their advice and do the colonoscopies a little more frequently than you would like to. But it's all in the name of preventing cancer. So if you have lots of polyps, you take out these polyps, you don't get cancer, and that's the way to do it. All right, so there is also a very interesting email that I'm going to read out and answer. And what I'll do is I'll read each part of the email because it came in multiple parts, and we'll talk about all of these interesting colonoscopy topics. And this is, again, stuff that I get asked constantly in the office, these kind of questions. So I figured it was a pretty good summary to go through. All right, so this email comes from a person named, actually, I'm not going to say the name because they give the full name, and the first name is Mrs., so I don't want to give the last name away. So it's Mrs. Anonymous listener. But this is somebody who subscribed to my newsletter, and you get this exciting ebook about colonoscopy when you subscribe to the newsletter, and then you'll get some of my weekly. You'll get a few of these weekly update emails about like just getting up to date with all the interesting stuff going on in GI, and then you'll get these like monthly newsletters that kind of summarize what's going on in the podcast. In case you don't have a chance to listen, obviously every episode you can kind of cherry pick what you want to hear if anything's interesting to you. And you get some behind the scenes, cool, exciting pictures of the podcast studio, etc., and whatever else I choose to send out on these monthly emails. So this is someone who signed up and then they responded to me immediately with questions, and let's go through it. So let's try to find the top of this email. Hi, Dr. Gandolfo. Thank you for making this video about preparing for a colonoscopy. She's talking about I have a bunch of YouTube videos also, if you have not seen them. There's some good YouTube videos on how to do bowel preparation. I covered a few of the different preps. I covered Sue prep, which you can kind of apply to all the liquid preps. I covered Miralax prep, which I show you how to make it and how to use it. And I covered Sue tab, which is a pill-based prep. And these are all just like educational videos about how to do the prep and what to watch out for and some tips. So if you haven't checked out the YouTube channel, you can do that as well. It's linked somewhere. I'll link it below also to the show notes here. I think the channel's name is Precision GI. If you're at YouTube, you can go to @PrecisionGI. Okay, it was very funny, thank you, and also very refreshing to see a doctor going through the steps / colonoscopy prep work yourself, kind of a practice what you preach concept. And that's true, I did drink the colonoscopy prep, although I have to say that the prep I drank on the video was not real prep, it was water, because I drank the real prep like a week before for my actual colonoscopy. So I didn't want to have to relive that experience, but I did have all of the memory of it, so I was able to act it out accordingly. Reminds me of a fantastic movie from the 1980s called The Doctor. I feel every medical student should be required to watch this movie. I feel like I have not seen that movie, but maybe I did when I was younger. Empathy is what I would hope to find in the medical profession. I do have a question for you relating to a few GI-related issues that I have questions on. All right. I did one of the mail-in poop kits By the way, even though I did it as cleanly as possible, I still feel sorry for the mail person who delivers these potent packages. I agree. So she's talking about a Cologuard test. She did a Cologuard test. And the mailman picked it up and was very excited to have that in the back of the mail truck. My test came back abnormal / blood in the stool, and I need to get a colonoscopy. So Cologuard, we've talked about this before. I have a whole episode on Cologuard testing about how it works and what they're picking up. And basically they give you a result, either positive or negative. So you poop in the box, you send it off to the company, they check for abnormal DNA and they check for blood in the stool. And if that comes, either one of those things comes back positive, they send you a positive result, and that means you need to get a colonoscopy to find out what's going on. So our patient here, or not, our listener here, had a positive Cologuard test. And the email continues, in my younger years, I had my gallbladder removed. Really, it disintegrated inside of me and even caused some rotting to a portion of my intestine. That's not cool. The surgeon removed the gallbladder, and I think he had to vacuum my insides from all the stones / mess he found, and had to remove the rotting intestine portion and reconnect the intestine together. I would agree that that's the right thing to do. So it sounds like she had like a necrotic gallbladder, like she had a gallstone attack or something like that, cholecystitis that became super bad and basically like ate through the wall of the gallbladder perforates and it leaks all of its ugly contents into the abdominal cavity, and it's a bad time in general if you want to stay alive, so you have to get all that stuff removed. He worked a long day on me to get things back together again. I have since had cranky bowels when there are longer times between meals. So if she's fasting, she has some issues. When I finally eat, there is urgency and a talkative, gurgly, painful gut. Probably too much information, but I call it either butt vomit or bleh. She wrote B-U-U-G-H. So that's how I would say that. I try to eat regularly to prevent this issue, and it's usually not a problem. All right, good. Butt vomit is not something that I think is a great thing to have. So, all right, here we go. First of all, would the colonoscopy search the area that the surgeon worked on to see if maybe the reattached section is now wearing out and needs to be repaired again? Nor does the scope not go up that I think she meant or does the scope not go that far up the intestines? Otherwise, what could be causing the bleeding? Okay, so a couple of things here. This is not a straightforward question. The bleeding, it sounds like she's not seeing blood. This is just the Cologuard test being positive, so anything could be causing that, anything from nothing to colon cancer. So the bottom line is you shouldn't really try to figure it out basically like from basic principles. You just need someone to look in there and find out what the problem is. There's no like reasoning your way out of this. If you have a positive Cologuard, you need a colonoscopy. And then you'll find out what caused the bleeding. And if you don't find anything there, then you can look further, but that's like the bare minimum. So who knows what it is, but it's a knowable hypothesis, so just get the colonoscopy and find out. Now, would the colonoscopy search the area the surgeon worked on to see if maybe the reattached section is now wearing out? No. Or maybe, who knows, if it was the large intestine, it would be seen on the colonoscopy, but the intestine doesn't just like wear out where you attach it. If this was done many years ago, it's not going to happen. So I don't know. That's just like some type of theory she has, but it's not founded in reality, I don't think. And that's the story there. Now, going back to this issue where she's fasting and then eats and then has like urgent diarrhea and all kinds of rumbling and discomfort and stuff. I mean, there's a lot of things that can cause that, but when you don't have a gallbladder, it could be related to an issue with bile acids, and sometimes you can see a GI doctor and they can prescribe you like a bile acid binding resin. Maybe you can try to take cholesterol or Welchol or cholestyramine or one of those things and see if it makes a difference in the incidence of having butt vomit, because that's something I would probably want to clear up as fast as possible. And that's something to think about. People also, when they have intestinal surgery or all kinds of, who knows what the plumbing looks like in there now after this surgery she had, but you think about bacterial overgrowth and you think about other problems like that. And you also think about when people have fasting, pain and discomfort with fasting, sometimes you think about ulcers or issues with stomach acid and gastritis, duodenitis, ulcers, etc. So stuff to look into that may have nothing to do with this positive Cologuard test. Okay. Secondly, I have been very afraid of colonoscopies ever since I heard Joan Rivers died from one. Would you please elaborate on this, and how common is death or injury from this procedure? What kind of injuries can occur, and what are the injuries like for the patients that have to deal with them? Effects of the injuries. How often do deaths occur, and in what situations? All right. So Joan Rivers, first of all, I have no insider knowledge here. I'm just going by news reports and what I can derive from being on the inside of the field and knowing how things go. I think she had an endoscopy, an upper endoscopy, not a colonoscopy, and died during that encounter. And I heard through the news or whatever it was that it wasn't just like a regular upper endoscopy. They tried to mess around with something on her vocal cords. I believe that was the story. They tried to biopsy something on her vocal cords. That should just never be done. I mean, the vocal cords have nothing to do with the endoscopy. A GI doctor should never really touch the vocal cords for any reason. That's done in a hospitalized setting with an ENT doctor who is with proper precautions to maintain your airway, because basically what happens when you mess around with the vocal cords, they spasm and you can't get air into your body and you die. So that's, who knows if that's what happened. I wasn't there. I don't know anything more than I saw in the paper, whatever many years ago this happened. But that's a freak type thing. And my feeling there is also that, unfortunately, these VIP celebrity type people, they get this special treatment. I call it VIP syndrome. I'm sure people, maybe I didn't make that up, but maybe I heard that somewhere. But it's when the doctors or whoever it is feels like they want to go above and beyond to take care of this person because they're special or important or rich or famous or whatever it is, and they deviate from the standard of care. And that's when bad stuff happens. You see it even in local communities where some bigwig millionaire guy comes in for health care and the family's well known in the area, and you have this feeling like you want to do special stuff for them for whatever reason, or you get pushed to do special stuff for them. And it's not a great idea because the standard of care exists for a reason, and when you deviate from it, bad stuff happens in terms of safety. And you start messing around to try to, quote, please the person. Hey, how excited would Joan Rivers be if we found this little vocal cord tumor and took it out while she was asleep, and she'd wake up and we just did it, and whatever it was, we biopsied it, and now we know. We don't have to put her through another procedure. We could tell her we took care of it because we're awesome doctors. But what actually happens is a tragedy. So I don't think that by having a colonoscopy you'll have a Joan Rivers situation. Although, these procedures have risks. There's no medical procedure that's zero risk. Getting your blood taken has a risk. Driving to the doctor's office has a risk. Filling out the paperwork has a risk. There's always something that can happen. So a colonoscopy or an endoscopy, they are considered invasive procedures. And there's levels to this kind of thing. Like there's some doctors that are very safe, and there's some people that cause lots of complications. And that's beyond really the scope of this talk. But how common is death? It's really so uncommon that it's something that, you of course it's on the consent form because we put everything on there. But how many people die from colonoscopies or endoscopies? I can count on zero hands how many people I've had die from a colonoscopy or an endoscopy. Although, if you do 1 million of them, you'll have a 1 in 1 million event. In terms of injuries and problems that we do consent people for these procedures, the big few are we do consent people for problems with anesthesia. Usually it's not like death complications, but anesthesia can cause issues with breathing. It can cause issues with your heart rate going down, because you're being put to sleep. That's all handled by an anesthesiologist, and on a routine procedure, none of that stuff happens. But there's always the possibility, and it's very treatable. But of course, 1 in 1 million type things, you can have an arrhythmia, something bad can happen under anesthesia, even though it's pretty safe stuff. Now, the more common thing that happens that's somewhat anesthesia related, but not really, is called aspiration. You can lose the gag reflex when you're deeply sedated, and you can have some aspiration of gastric contents or even just saliva or mouth contents into your lungs because you're not coughing, you're not able to protect your airway, and that can cause issues with, after the procedure. You can have fevers, chills, pneumonia even, and of course that pneumonia can be very dangerous, but these are somewhat rare events. That being said, it's something you do hear about in practice. Typically, it's a self-limited thing, or it is treatable with antibiotics. But sometimes people end up in the hospital after an aspiration. How many times have I seen that happen? Maybe once in my life. And just for the purposes of numbers, most GI doctors have done well above 10,000 procedures, 20,000 procedures over the course of their mid-level career. So it's not like I'm talking about doing 50 cases here. It's very rare to have a major issue after a procedure like this. The stuff people read about on the internet or hear about from a relative, the scariest one is called perforation. That's when the scope can injure or put a hole in the bowel. There's various ways that can happen. Fortunately, in good hands, it's extremely rare. The in studies, they say it's less than 1 in 1,000. In practice, it's probably less than 1 in 10,000 if you're in good hands. The people who get perforations, unfortunately, previous bowel surgery does increase the risk a little bit if it's in the colon, or if you have adhesions, really like radiation to the colon or other issues there can cause it, or if you have a tumor that's causing a narrowing and someone tries to push around it, or if you have severe active colitis and someone tries to push around it, that's a recipe for a perforation. Luckily, they're pretty rare events, and on a person with none of these issues, they're exceedingly rare. The other issues like bleeding or having an infection related to having a procedure are very rare also, and those are the big ones that we warn people about. There's all kinds of other oddball things that can happen, splenic injury and other stuff, but these are it's like being struck by lightning. They're so rare that it's you can psych yourself out on these things, but unfortunately, or I should say fortunately, these things are really rare, and fortunately, the colonoscopy is a life-saving procedure, and we find lots of polyps and things that removing them, reducing the risk of cancer, really reduces, makes the procedure a net positive as opposed to a risky situation. Okay, so the next part of the email, which is now becoming like a novel, why does having a colonoscopy make it so you don't have to have another colonoscopy in 10 years? It sounds like, from a patient's perspective, 10 is a magic number, but why? Doesn't our bodies always change? Could something occur in less than 10 years without us knowing it that another colonoscopy would help prevent? Would you please explain why it's not necessary to have another colonoscopy in less than 10 years? So this comes from just guidelines, basically, that we know that the sequence of having a polyp that's an adenomatous polyp, meaning like a precancerous polyp, to have that turn slowly into cancer takes on average 15 years, maybe 10 years, but usually longer than 10 years. So we say that if it's totally clean and you saw a good doctor that has a high adenoma detection rate and has a good look at everything, and you were well cleaned out and you have no family history and you're not smoking and drinking tons of alcohol and doing other high-risk things, then 10 years is a pretty safe number. Some people shoot it a little earlier than that, but 10 years is the recommended number of years. So it's not that it's magically protective. It's that if you have nothing as of today, it's very rare that you would grow a cancer in 10 years. And most of these things that happen in 10 years are because something was missed. There was a polyp there that grew into cancer undetected because it wasn't picked up on the first colonoscopy, or the prep wasn't very good and part of the colon was not seen by the doctor and they didn't bring you back earlier for whatever reason. These are all things that influence these guidelines, why 10 years is the absolute longest you should go, and that's really in perfect circumstances. Now, if you had a poor clean out or if you had polyps, etc., the doctor really should bring you back earlier. And there's guidelines for that too, and I feel like I've covered those before too, so who knows. I can't even remember what I talk about in this thing, so how could you? But the deal is, why is it not necessary? It's just that it's very low risk to have a problem come up in less than 10 years. So that's really it. Your bodies do change, stuff could happen. There are cases where you can have nothing for sure, and then a cancer can grow in 5 years. Some cancers grow very rapidly, and this is just a general guideline, but that's where it's at. And here she goes, thank you for your podcast. It's very educational and interesting. Lots of good content to us lay people. Well, thank you. I'm glad that you're listening, and hopefully this is helpful to you as well. Also, do you travel to other areas of the country to perform colonoscopies? It's hard to find good doctors that are knowledgeable, experienced, thorough, and caring. Thank you again for your podcast and helping to educate the public on important issues. Well, thank you. That's very flattering. But no, I don't travel to other areas to perform colonoscopies. That would be kind of cool. I could be like I could pack the van with my colonoscopy gear and go on the road. But no, you can't, because I have a medical license that is, it's state specific. So every doctor has to have like a license in their state. You can't just like travel around and practice medicine, in a van somewhere down by the river. So that'd be pretty cool. But no, I cannot do that. And there's more. But wait, there's more. There's a second email right after the first one. More thoughts. Can I add a PS to my original email below? I failed to mention that I have health insurance that my coworkers called Kaiser Experimente. That's pretty funny. She's talking about Kaiser Permanente. That's like California and probably somewhere else. It's the big healthcare conglomerate. She writes, I personally wonder if there is a conflict of interest to have a medical insurance provider who also provides medical services, which may be a factor in what I'm experiencing. Yes, of course that is a conflict of interest, but big business interests say otherwise. So who are we, peons, to talk about conflicts of interest. Of course, these insurance conglomerates are a ridiculous conflict of interest. They think of Optum or some of the other things. They own the pharmacies. They own the doctors. They own the insurance company. United Healthcare owns them. It's or whatever. They own each other. Whatever it is, it's all the same company. And it's just, of course, it's ridiculous. You order a test has to go through or you order this is a bad example, but you order a prescription that has to go through their pharmacy and they deny it because they want to give something else. It's just enough. It's enough. It's a monopoly. But who are we to fight it? Anyway, Kaiser, I will call them KP, sent me a FIT, F-I-T, fecal test, which they do every year, which is great to be proactive with screening. However, my result came back she writes, my result came back a generic letter, I guess in a generic letter, saying I need to schedule a colonoscopy because of abnormal occult blood in the sample. I called the scheduling phone number and they started listing all the things I need to take before the procedure really fast. I asked them if I get to talk to a doctor that is doing the procedure and they said no. They schedule a nurse call before the procedure to answer questions. So what they're talking about here is, well, first of all, she's talking about a FIT test, not a Cologuard test. But it's the same idea. If it was positive, you need a colonoscopy. And she's saying that they basically want to do what's called direct access colonoscopy, which is great. I do it in my office. It's been pretty cool. People just sign up. They come on in. We call them on the phone, and they get the prep, and everything's good. And so far, it's been going well. But we often have patients that want to talk to the doctor who's going to do the procedure, and that's totally reasonable too. So we have regular, office visits available for pre-colonoscopy appointments, but not everyone wants that. So we do both. It sounds like Kaiser is really just going more toward the direct access pathway, which is, I understand because they're a big place and they don't have time to see everyone in California for their colonoscopy to do a hand-holding visit beforehand. But some people want that, and that's totally cool. I probably would want that too. So anyway, here she goes. They schedule a nurse call before the procedure to answer questions. I want to be able to meet the person who will be working on me ahead of time. Isn't that important? I don't even know the name of the doctor who will be doing the procedure. Yes, it's important if you want to meet the person that you're able to meet them. That's the problem with some of these healthcare systems. You're kind of, you have to abide by whatever policies they have. So I don't know. I guess you got to go outside the system, but you can't because you have health insurance through them. So you just got to do it. I think you just do it. What else can I say? I'm sure that it will be fine, but I can't help you with these systemic issues. She writes, do you take this insurance? Ironic thing is I will be visiting New York for one day in the summer, but it is for sightseeing. It probably wouldn't work out to be doing prep work while traveling. Not a pretty picture, probably. Anyway, thanks in advance for your time and thoughts. God bless. All right, so that's the end of the email saga. But in all seriousness, I like that email. It was good, and thank you for writing this email to me because it's very helpful to illustrate some of these points. But no, I do not think that it's a great idea to come to New York to have a colonoscopy on your one-day sightseeing visit. It will not be great for you, I don't think, at all. And I don't really think that's a great idea at all for me either because you want to meet me first and you would be coming in and, well, God forbid, there's some issue that comes up or there's a big polyp that, I don't want you to travel the next day or whatever it is. So it's just not a good idea. Just go somewhere locally, get the thing done. You will be okay. And I think it's just best just to get it done because these fecal tests sometimes pick up early cancer or something like that. And won't you be happy that you found it early and didn't wait and procrastinate on this thing because you're worried? And even though you have good reasons to be worried about all these things, it's still it's better just to do it, I think. That's my advice. So that is the story for this episode. I said it was going to be short, and in classic Gandolfo fashion, I stretched it out to a ridiculously long episode, but hopefully you enjoyed, and please submit your questions to me like our friend did, and I'll dissect the questions on the podcast if I have the time to do it for your listening pleasure. All right, take care until next time. Goodbye. I hope you enjoyed listening to this episode of The Real GI Doc Show. Please subscribe to the show on Apple Podcasts or your favorite podcast player to catch my next episode. If you really want to show your appreciation for the show, take a moment to rate and review the show on Apple Podcasts. It only takes a few seconds and is the best way to get other people to discover the show. If you use social media, you can find me under the handle @RealGIDoc, so feel free to follow, leave a comment, or just say hi. If you have a question about something gastro-related that you'd like me to answer on an upcoming episode, go to realgidoc.com or use the link in the show notes to leave me an audio question.
That's it for this episode of The Real GI Doc Show. Make sure to join Dr. Gandolfo next time to explore another interesting topic in gastrointestinal health. And remember, the views and opinions presented in today's episode are for informational and entertainment purposes only. Nothing discussed in this episode should be considered or used as a substitute for medical advice, diagnosis, or treatment. If you're experiencing a health issue, please consult with a doctor or a medical provider in your area. Thanks again for listening to the show.